Progress.
Can we start, Rajendra?
Yeah, I will start.
Good evening.
Good evening, sir. Good evening.
Good evening.
So, PRC sir, good evening.
Good evening, sir.
Good evening, sir.
Yeah, we'll start the meeting. Good evening to everybody. On behalf of IAP TNSA Mondanda, I request our dynamic president, Dr. Ramesh Babu, to deliver presidential address.
Thank you, Dr. Rajendran. Respected chairperson, Dr. Radhika Raman, madam. Respected moderators, Dr. Benjamin and Dr. Sudha, madam. And respected judges, PRC sir, Annamalai sir, and respected office bearers of IAP TNSC, and respected dynamic secretary, Dr. Rajendran, for his tireless efforts in successfully conducting every week this PG teaching program. And dear presenters, wishing you all the best for this presentation. Thank you once again for this opportunity. Over to Dr. Rajendran to carry out the proceedings.
Thank you, Dr. Ramesh, for your kind words. And respected our president, Dr. Ramesh Babu, and President-elect Dr. Suresh Balan, and President 2021, Dr. Ismail, our Treasurer, Dr. Gopal Subramaniam, and our AAA, Dr. Thirumurugan Sarayan, Dr. Dashani, Editor, and Joint Secretary, Dr. Balasubramaniam, and Vice President Annamalai Vijayaraghavan sir, and Central as well as State EB members. On behalf of IAP TNSA, welcome one and all. I welcome all the judges, Dr. Janani Shankar, Dr. P. Ramachandran sir, Dr. S. Ramesh, Dr. Ramachandra Mohan, Dr. S. Srinivasan sir from Pondicherry. And I welcome today's chairperson, Dr. Radhika Raman. She is a senior consultant of emergency medicine, Kanjigamodi Child Trust Hospital, Chennai. I welcome madam.
Thank you. Thank you.
I welcome today's moderator, Dr. M. Benjamin Sagaya Raj. He is currently a professor and head of the Department of Pediatrics, Savitha Medical College and Hospital and Chennai. He is one of the active member to increase our IIP membership strength. I welcome Dr. M. Benjamin sir.
Thank you very much, sir.
Yeah, I'll welcome Dr. Sudha Yagambaram. She is deputy head and senior consultant in pediatric nephrology, Dr. Mehta Multi-Specialty Hospital, Chennai. I welcome Dr. Sudha.
Thank you, sir.
So, and I welcome all the postgraduates from Savitha Medical College and Hospital, Chennai, and Dr. Harita, Dr. Benazir, Dr. Charan, and who is going to take part in the case presentation. And it's almost 3 years we are conducting postgraduate clinic all over India, and really it's overwhelming response. I really hats up to you, and as well as viewers, as well as our postgraduates and all the institutions all over Tamil Nadu and Pondicherry. And now it's over to Dr. Radhika Raman, madam. Please take care, madam.
I welcome today's participants, delegates, as well as the committee members for this presentation. And I think we'll start off with the case presentation itself. And Dr. Benjamin and Dr. Sudha will read the case. And I think I will just put in a few words. And I think without much wasting time, we can start off with the presentation.
Madam, audio konjam slow barke konjam come forward, madam.
Is it okay? Okay, no? Am I audible?
Now better, madam, better.
Thank you. Thank you.
Dr. Benjamin, please.
Yes, sir.
Yeah.
Now I would like to, Dr. Harita. We have three students. One is Dr. Harita, another one is Dr. Benazir, and Dr. Charan. So three of them are there. Now I would like to ask Dr. Harita to start presenting this case.
Good evening, sir. Good evening, one and all. Today I am here to present the case on a child with generalized body swelling. So shall I start, sir?
Yes, ma'am.
So we Here is a child named Durga Devi, a 3-year-old, 6-month-old female child, second born of a non-consanguineous marriage, coming from Ranipet, Velur, brought by mother whose reliability is good, with chief complaints of fever for 4 days, swelling around both eyes and face for 2 days, decreased urine output and abdominal distension for 1 day, and swelling of the bilateral lower limbs for 1 day. History of presenting illness. So the child had a fever for 4 days, which was a low-grade intermittent fever and not associated with chills and rigors. It was relieved by taking medications, and which was followed by a periorbital edema and swelling of the face after 2 days, which was insidious on onset, noticed more in the morning after waking up from sleep, and gradually decreased as the day progressed. On the next day, mother noticed a uniform abdominal distension, which was also insidious on onset, which was not associated with any abdominal pain, vomiting, or diarrhea, but was present with bilateral pitting pedal edema, followed by which a child had history of decreased urine output for 2 days in the form of passing urine once or twice a day. And the child usually voids around 6 to 8 times on other days. And also, child had a history of cold and cough for 2 days. There was no history of breathlessness or increased precordial activity. There was no history of jaundice, loss of weight, loss of appetite, or high colored urine. And there was no history of crying while passing urine, no history of passage of cola colored urine, no history of any skin lesions or sore throat prior to the onset of illness, and there was no history of headache, altered sensorium, visual disturbances, or seizures. And there was no history of any skin rash, arthralgia, or joint swelling. And there was no history of any drug ingestion prior to the onset of illness, or no history of insect bite. No history of gum bleeding or bone pain, and no history of easy fatigability or lethargy or loss of weight present in this children. So moving on to past history, child had history of similar illness 5 months back, for which she was hospitalized. According to the mother's history, she was started on oral medication. She was given 2 tablets in the morning. After admission, she was taken some routine blood tests and urine tests, and the child was started on those medications. And child was discharged after 10 days of admission, as she improved clinically and was advised to continue the same medication for 6 weeks. But parents were advised to come for follow-up, and the course of the disease was also explained. But patient didn't turn up, and but had given tablets only for 6 weeks. No history of any blood transfusions in the past for the child, and the mother was counseled about the nature of the disease and its treatment also. Sir, shall I continue, sir?
Madam, would you like to ask any questions?
Yes, sir. Harita, what do you think could be the cause of edema in this child here?
The child had edema mostly involving the periorbital edema, that too after getting up from the sleep, ma'am. I think it's after following a URI, ma'am. So more favoring of renal cause.
Okay. So early morning edema around the eyes, and you also said that it disappears during the later part of the day, right? So that favors your renal. But following a URI, that always doesn't favor a renal. Sometimes yes, but yeah, go ahead.
Yes, ma'am. Not always, ma'am.
Not always.
You had mentioned about chills and... Sorry, continue, madam.
So the main thing in your, which you have highlighted, is early morning, which disappears. So that points towards your renal. Sir, yes, sir. Please, sir. You wanted to say something.
No, I just wanted to ask you certain questions. Just like you mentioned chills and rigor. Why do you want to ask chills and rigor?
Rule out any other infections like UTA.
Okay. And you had mentioned about skin lesions. Why did you mention about skin lesion? No history suggested of any skin lesions you mentioned. What do you?
Rule out pyoderma, sir.
Any other condition? Any other condition? Renal involvement with skin problem?
HSP also we can ask, sir. Any?
Okay. Any other condition other than HSP?
SLE also we can ask, sir, any rash or a malar rash or discoid rash.
Why did you ask about blood transfusion?
Sir, secondary causes, hepatitis also is a secondary cause.
Which hepatitis?
Hepatitis B, sir. Or,
and why did you ask about insect bite?
Bee sting is a secondary cause for nephritis.
Okay.
So, what do you think are the causes for edema in a child who presents just as you said? Is it only thinking in terms of edema, or what are the other causes that can, where a child can?
What are the other causes of edema, madam is asking?
Progress.
The causes of edema, it may be congestive cardiac failure in cardiovascular system, ma'am. Most commonly right-sided heart failure. And other causes, renal causes includes nephrotic syndrome, AGN, and angionuretic edema, ma'am, lymphedema, and liver failure also there may be edema. And protein-losing enteropathy, kwashiorkor.
And you also, I think, mentioned about the increased precordial activity. So,
sorry, ma'am, I'm not.
You also spoke about, asked a question about increased precordial activity. So, yes, do you think it's very easy for a mother to make out and why it was?
Ma'am, some mothers can notice when the child, when they are having the child against their chest. Some mothers may notice.
And but why? What was the reason that you wanted to ask about the increased precordial?
Ma'am, if the child is in any CCF, I want to rule out.
So you're thinking in terms
whether
of
child is in
some
cardiac
complicated renal problem or a cardiac problem or right. And again, gum bleeds and bone pains. You had asked about gum bleeds and
secondary causes of nephrotic syndrome, lymphoma and leukemia are also there, ma'am. So I wanted to rule out those for gum bleeding, bone pain, loss of weight and appetite and all.
Your history of cola colored urine?
And for acute glomerulonephritis only.
Any other places, a condition which might cause, you said, no? After URI, the child is having a swelling. So any nephrotic syndrome which might present in that way? Or a nephritic syndrome? A URI, then you have cola colored urine.
Sharan and Benazir can also answer.
IgA nephropathy.
Yeah, so IgA nephropathy is the other condition.
okay, and then asked about the amount of urine the child pass. Is there any mention about the reduced amount of urine the child is voiding?
Mother told the child usually used to void around 6 to 8 times a day, ma'am. But for the past one day, she noticed that the child voided for at least only twice a day.
Color of urine, like was it high colored or?
It was normal, ma'am. It was not high colored, ma'am. Pale yellow.
Did you ask for any frothy urine?
Ma'am, I asked, ma'am, but mother couldn't differentiate, ma'am.
Okay. So what do you think, if there is frothy urine, what do you think it could be because of?
Because loss of lipids in the urine, the urine may be frothy, ma'am.
It's usually the proteinuria which is causing that.
Proteinuria.
Okay. So frothy urine. Okay. So that gives you an idea that it could be a nephrotic syndrome.
Yes.
Okay. So with your history, what is your cause for edema now? So it's renal. That is what you've come to a conclusion.
Yes, ma'am. It was renal. Shall I proceed, ma'am?
Yeah.
So moving on to antenatal history, mother's age at conception was 26 years. Pregnancy was registered and mother was immunized in a nearby PHC. Pregnancy was confirmed by UPT at 45 days of amenorrhea. No history of fever with rash or post-auricular lymphadenopathy. No history of drug intake or radiation exposure. No history of diabetes mellitus, pregnancy-induced hypertension or hypothyroidism. Antenatal scans reveal no anomalies. No history of polyhydramnios or oligohydramnios in the antenatal scans. And had taken iron and folic acid supplementations regularly.
What could be the causes if there is a positive family history? for a nephrotic syndrome. So what could be the causes? What could be the causes for nephrotic syndrome if there is a positive family history?
Alport syndrome and any genetic causes can cause nephrotic syndrome. Like mutations in the NPHS1 to finish type of
Yes, so
nephrotic
first would be.
So I don't
Okay,
know.
so your mutations, your congenital nephrotic syndrome,
Yes, ma'am.
it can be congenital or it can be even genetic causes like your NPHS1, WT1 mutation. There are multiple causes. Even IgA nephropathy also can run in families. FSGS also sometimes can be familial. So depending on the genetics. Okay, and if suppose there is a large placenta at birth,
Yes.
they say the child has a large. So what could be then what would you think about?
And they have congenital nephrotic syndrome when the weight of the placenta is more than 25% of the body weight of the child. We can think in favor of congenital nephrotic syndrome, ma'am.
Okay. So
The
when
child-
will you call it as congenital nephrotic syndrome? When they present, what is the definition for congenital nephrotic syndrome?
When the child is diagnosed as nephrotic syndrome, the first 3 months of life, it is called congenital nephrotic syndrome, ma'am. The child will be sick looking with excessive loss of protein in the urine, and the child may need immediate attention in the form of giving diuretics and other supportive care, ma'am.
It's not always they're sick looking. Okay. Their edematous, sometimes even edema may not manifest immediately. It might take some time also. But it's usually it's the less than 3 months when they manifest, then it is congenital nephrotic syndrome.
So what other antenatal causes are you thinking of? You asked about rash. As a cause of
Ma'am, sorry, ma'am, I'm not able to hear you, ma'am.
You asked about the rash and all that. So what are the causes are you thinking of from the antenatal history?
Toxoplasmosis, rubella, cytomegalovirus, and all those can cause secondary causes of nephrotic syndrome, ma'am.
Any other infection?
Ma'am?
Any other infections which can cause nephrotic?
Ma'am, head.
Yeah.
Mother.
Any other infections that can cause
HIV.
Yeah.
Syphilis, HIV.
Yeah, right. Syphilis, HIV. Right.
Harita.
Shall I proceed, ma'am?
Yeah,
Yes,
proceed.
yes,
Proceed.
Can I make a request?
Sir?
Can you show from 3rd slide to 6th slide? Sorry, I lost a connection. You said the history of presenting illness. From that, just 3 more slides. You just run the slides for 30 seconds. That is enough. Yeah, please go to the next one. Next one, please. Next one. Next one. Next one, please. Thank you. I got it. Please proceed. I'm sorry for the interruption. Sorry, I missed the slides. Thank you.
Moving on to natal history, it was a term normal vaginal delivery. Birth weight was 2.74 kg and child cried immediately after birth. Child passed meconium and urine on the same day. Postnatal history, no history of NICU admission, and child was exclusively breastfed till 5 months of age. Developmental history, child attained age appropriate milestones and developmentally normal child. At present, child is able to hop on one foot and alternate feet going downstairs, copies, cross and bridge with blocks, plays cooperatively in a group and says a song or poem and tells stories. So immunization history, child received age appropriate vaccination till 1.5 years of age according to national immunization schedule. PCV vaccination was not received. Pneumococcal conjugate vaccination was not received, and no other special vaccinations were given. Diet history, consumes both vegetarian and non-vegetarian food. and consumes of about 950 calories against 1200 kilocalories and 16 grams of protein against 22 grams of protein, the deficit of 6 grams.
Vaccines, I think.
Ma'am?
Vaccines? What are the specific vaccines actually you asked for? Apart from pneumococcal?
Apart from pneumococcal, what are the other vaccines
Specific
you want to
vaccines
ask?
are important that you ask for.
Influenza vaccine.
Varicella.
Varicella. And the diet also, anything else specifically you need to ask? Regarding the amount of protein the child receives? Whatever you
In nephrotic syndrome, the child will need a high protein diet, ma'am.
So maybe you can also ask about the types of protein the child is taking. Type of protein the child is taking, like high biological value. That again is important.
Rita, you said high protein. So what do you mean by high protein? You're going to plan to give the child more protein than required, or that is required? What do you think we should do?
3 to 4 grams per kg per day. I consider it as high protein. Normally, the requirement of the child is 1.5 to 2 grams per kg per day. Maybe for a child with nephrotic syndrome, 3 to 4 grams per kg per day will be needed.
See, actually, what they say is in nephrotic syndromes, even if you're going to give more of protein, that is not going to increase the albumin in the blood. It is going to cause more proteinuria only. Okay. So too much of protein if you give, then that is going to cause excess proteinuria, and that might lead on to your glomerulosclerosis, and it might further aggravate the renal failure if there is. Okay, so you should be very careful when you advise the diet. You should give the regular diet, but you should give a good protein diet like your egg white. So which is, but you should not give an excess of what that is required always. Okay, and coming on to the immunization history, when do you think in a nephrotic child, when do you think the child will be immunosuppressed? When do you think the child is immunosuppressed?
When the child is receiving steroid of more than 1 milligram per kg per day, ma'am.
Okay, see, when the child receives more than 2 mg per kg per day for 2 weeks, or at least if the child is more than 10 kilos, then and if the child receives 20 milligram per day, then you consider as immunosuppressed. Because when they were asking about the vaccine, you said about varicella. So you should know when to give a live vaccine, when not to give a live vaccine. So when this condition, when the child is immunosuppressed, what the definition which I gave you, it is there in your ISBN guidelines. So in that condition, for 4 weeks, you defer live vaccines.
Yes.
Okay, so that is when you consider the child as immunosuppressed. And what about your PCV vaccination? PCV, what PCV would you advise for these children?
Ma'am, in children less than 2 years of age, pneumococcal conjugate vaccine is given, ma'am. 3 doses. If the child is more than 2 years of age, 2 doses of pneumococcal conjugate vaccine is given, followed by a polysaccharide dose 8 weeks apart. 8 weeks apart, considering the previous pneumococcal conjugate. If the child is more than 5 years old, 1 dose of pneumococcal conjugate vaccine followed by a polysaccharide 8 weeks apart.
Very good. So this is the your schedule for your pneumococcal vaccine. Now there are multiple immunosuppressive therapies which we give for children. Now suppose the child has received mycophenolate or levamisole. What would be your advice on live vaccines?
Ma'am, for levamisole, after 3 months of stoppage of the drug, vaccines, live vaccines can be given, ma'am.
Okay, you should be very strong in your vaccinations. Go through the ISBN guidelines. It's any immunosuppressive therapy, it's going to be 1 month. For cyclophosphamide, it is 3 months, right? For cyclophosphamide, it's 3 months. The rest of the immunosuppressive is 1 month. And rituximab is 6 to 9 months. Because your B cell memory is depleted, your B cell is depleted. Okay. So that is why it is after 6 to 9 months. Now, in case, what would you advise the household contacts, the siblings? A child is on 2 mg per kg of steroids. What would be your advice for the siblings?
If they have an younger child, oral polio vaccine should not be given for those children who are residing there. Instead of that, IPV can be given, ma'am.
Okay.
And other household contacts can also take influenza vaccine annually, ma'am.
Yes. So annual flu vaccine should be given to all these, all the household contacts. Okay. Okay. Proceed.
I think regarding the diet, you can follow the recommendation of NIN and ICMR, National Institute of Nutrition and ICMR guidelines.
Shall we proceed, ma'am?
Madam is asking, as per the ICMR, what is the diet that you will advise?
No, you can go through that. I said that. Okay. That's what can be followed.
Okay.
Okay.
We can continue.
So moving on to socio-economic history, 4 members in the family. They live in a Pakka house with 1 main room, a separate kitchen with adequate ventilation and an attached bathroom. Father is a mason and mother's monthly income is approximately 12,000. They drink boiled water and belong to upper lower class according to modified Cook's scale. So family history, it is a non-consanguineous marriage, no history of similar illness and renal diseases in any family members, no history of recurrent miscarriages or abortions, and the other sibling is 6-year-old male child with no similar complaints. Contact history, no history of contact with any open case of tuberculosis. So summary, it's a 3.5-year-old female child, second born to non-consanguineous marriage, presenting with periorbital edema more during the morning after getting up from sleep, followed by swelling of both the feet and progressive abdominal distension with decreased urine output, with history of similar illness in the past. The probable system involved is a renal system and the probable diagnosis is nephrotic syndrome. Shall I proceed, sir?
Yeah, proceed for the examination.
So, general examination, child was examined on day 6 of hospital admission. On examination, child was awake, looking around well, interacts with mother, afebrile, no pallor, icterus, cyanosis, clubbing or lymphadenopathy. Bilateral pitting pedal edema was present. Head to foot examination, face edematous, no facial dysmorphism, head normal in size and shape. Periorbital edema present, eyes normal, no cataract, ears normal, no preauricular attacks, oral cavity normal, or dry skin, nails were normal, abdomen mildly distended and no skeletal deformities were present, spine normal, no Cushingoid features or no vulval edema present. Vitals, heart rate was 106 per minute. Regular in rhythm, normal volume and character, peripheral pulses equally felt in all 4 limbs. Respiratory rate 24 per minute, abdominothoracic type of respiration. BP 90/64 in the right upper limb in sitting posture. Systolic lies between 58 to 98 centile and diastolic between 98 to 95 centile. And CRT is less than 2 seconds. Temperature 98.8 degrees Celsius in the right axilla with digital thermometer. Moving on to anthropometry, the dry weight of the child was 11.8 kg against 15 kg, which is expected. It lies between 0 to -2 standard deviation according to WHO growth chart. It's normal, and the height of the child is 92 centimeter. Expected 98 centimeter. It also lies between 0 and -2 standard deviation. Is normal. BMI is 14.5. Expected 16.5, and child is underweight. Mid-arm circumference is 13 centimeter. Head circumference is 48 centimeter, which lies between 0 to -1 standard deviation and is normal. Weight for height is lies between 0 to +1 standard deviation, which is also normal.
Once again, Arita, you had mentioned. Have you mentioned about BCG scar in the examination? You didn't mention about the BCG scar. And have you mentioned about any Manto test or any test has been done for this patient?
The previous admission, mother told, sir.
So the Manto was not given.
Mother told that they had given an injection in the skin. She mentioned, sir. After that only they started, but I didn't mention here, sir.
So you have not mentioned about the BCG scar.
BCG scar I didn't mention.
Yeah. Okay.
Why did you really make a specific mention about skeletal deformities? When you're very specific, you're looking for something. Why did you make a mention?
Others can give an answer, can support her.
If you have a child with a congenital nephrotic syndrome, again, what else do you look for in the general examination?
Some syndromes with nephrotic syndrome, Algeric syndrome.
So what do you look for? What are the striking features we can do? Sometimes you may have a child with, like coming in very early, small young infant with maybe 3 months old or so with nephrotic syndrome. Started at 3 months, you may have an infant with a congenital nephrotic syndrome. Important to know whether the child has got a microcephaly and look at the eyes, examine the eyes. So there's no what are the things that you're going to look for in a congenital nephrotic syndrome. And
there are some syndromes.
Yeah, in an oral cavity in a child who's been on either an immunosuppressant or a child on steroids for a very long time, again, look for can be an oral thrush, and I think that's really important.
Okay.
And edema all over there, like sacral edema. You may have a child who's really, having an anaphylaxis. So it's important to mention edema. In anthropometry, I think. Any questions, Sudha, on anthropometry?
Blood pressure. Can you go to the blood pressure slide? BP. Okay. So now, how do you measure blood pressure? How do you choose the cuff for the 3.5 year old child?
Ma'am, the cuff should encircle at least 2/3 of the arm, ma'am, and it should be a 1 inch above the cubital fossa, ma'am.
So what you need to see is the bladder. Okay. So the bladder length should be 80% of the arm circumference, and which should cover the 40%. So that is what you should see to check for the bladder cuff size. And now you have mentioned it as 50th and 90th and diastolic between 90th and 95th centile. What is the definition for hypertension? This child is having a normal blood pressure.
The diastolic.
How did you get between 50th and 90th? What charts do you use?
Ma'am, I first plotted the height, ma'am. Height centile was taken, and according to the height centile, I saw at what level the child's BP is lying in which centile, ma'am.
Actually, you have the your AAP guidelines for your hypertension, the newer version. I think it's 2019 or I'm not very sure which year. So in that already you have the charts in which you have the height as well as the centiles plotted in that. And then we mark it accordingly. It's usually 90th or 95th, according to the charts. And your definition for hypertension is any BP above the 95th centile, 95th percentile for that age and height. Okay, age, height, and sex. So this is what is seen. Okay, so you just go through that AAP guidelines where they have the definition for hypertension, elevated blood pressure. What is elevated blood pressure? It's above 90th centile. So it's usually the centiles are there in that particular thing. Okay, go through the charts.
Okay.
And Harita, you said about the eyes cataract. Anything else would you like to look for in the eyes if a child is in nephrotic syndrome who has already taken a steroid for quite some time? Other than cataract, anything else as an ophthalmologist you want to refer and ask the ophthalmologist to check for?
Sir, intraocular pressure also should be checked, sir, because glaucoma can also be there when the child is on taking steroids.
Okay. And if it is going to be a congenital nephrotic syndrome, what can you see in the eyes? Or any syndromes that is associated with the eyes?
Microcornea, sir.
Lowy syndrome, cataract can be there, sir.
Okay.
Another one is a Pearson syndrome where microcoria can be present.
What is microcoria?
The pupillary, interpupillary distance,
a fixed narrowing of the pupil.
Narrowing of the pupils.
It's a fixed narrowing of the pupil. Okay. Okay. Proceed.
Again, this dry weight there. Can you go back to the anthropometry? So how did you determine the dry weight?
Ma'am?
How was the dry weight determined?
Sorry, ma'am. Can't hear you, ma'am.
Just comment on the dry weight. How was it determined? Dry weight.
Ma'am, dry weight. Ma'am, the child visited a local practitioner when the child had a fever and URA, ma'am. So mother told when weight was checked there, it was 11.8 kg, ma'am. That time the child was not having any edema, ma'am.
And that was how long back? Can you take that weight?
Ma'am, child came here on day 5, ma'am. That is 5 days
so
back.
Before that, the child had it.
Before
the start
that,
of illness.
Yes, ma'am.
Okay.
Proceed.
Systemic examination. So I would like to examine the abdomen, ma'am. So inspection. There was a mild distension of the abdomen, and all the quadrants of the abdomen moved equally with the respiration. Umbilicus was normal and inverted. No visible veins, scars, sinuses, or striae were seen. Skin over the abdomen was normal. No visible peristalsis or pulsations noted. Hernial orifices were free and flanks were free. External genitalia normal and no vulval edema was present. On palpation, abdomen was soft on palpation, no warmth, no tenderness, no guarding and rigidity, no organomegaly. Liver span was 6.5 centimeter. Percussion, no shifting dullness or fluid thrill. Auscultation, bowel sounds were heard and no bruising.
The patient was having a slit-like umbilicus, right?
No,
Was the
sir.
umbilicus slit-like? No.
No, sir. No, sir. This child didn't have slit-like umbilicus.
Okay. Was there any abdominal wall edema? You never mentioned about the abdominal wall edema.
Sir, there was only a mild distension, sir.
Okay. Then what is puddle sign?
Sir, in case of minimal ascites, the child can be examined by putting the child on a knee elbow position, and the child is percused in the center of the abdomen, sir. The resonant abdomen, which was earlier, will become dull, sir.
From periphery to the center.
From periphery to the center.
And since you said there's no shifting dullness and fluid thrill, you are supposed to check for the puddle sign, since there may be a minimal ascites, isn't it?
If there is tenderness in the abdomen, what do you think can be the cause?
Ma'am, we can think of
syndrome. No.
Peritonitis, ma'am, subacute bacterial peritonitis.
Okay. Anything else which can cause tenderness? And you have also mentioned about guarding.
Ma'am, in case of hypovolemia, the child may have abdominal pain also, ma'am. Okay. Severe abdominal pain. In case of hypovolemic status in nephrotic syndrome, the child may have abdominal pain.
Why do they get that?
Ma'am?
Why do they get that in hypovolemia?
Ma'am, in underfill theory, if the child's intravascular volume is depleted and there is a shift of fluid to the interstitial space, the intravascular volume will be lost and child will be in a hypovolemic state, ma'am.
Yeah, but the abdominal pain is mainly because of flanking perfusion is very less. Okay, in hypovolemia. Anything else which can cause guarding rigidity? This child is on steroids. So remember that even steroid can cause tenderness and pain. They can have steroid induced
gastritis, gastritis
or a pancreatitis. Again, all these are causes where they can have tenderness. They can come in with abdominal pain, abdominal wall cellulitis. Okay, early on the erythema may not be very visible, but again they can have tenderness in the pancreas. And of course, renal vein thrombosis is the other cause which can cause abdominal pain. Right? Well, how do you know that the child has got a renal vein thrombosis?
Renal vein thrombosis, the child may have hematuria, ma'am.
Right. And definitely you can have a tenderness The loin,
Tenderness.
the kidney might become palpable, maybe palpable. Again, that will give you clues that this can be a renal vein thrombosis.
Okay.
Why do you think there is a reason? What is the reason for spontaneous peritonitis more common in nephrotic syndrome?
So there will be loss of immunoglobulins and complement C3b cell, which is more important for the phagocytosis of the encapsulated organisms.
Any
Loss
other
of
reason?
those in the urine will make the child more prone to infections caused by encapsulated organisms. So,
Any other reasons? PGs? Others?
A loss of opsonins.
Okay. Coprolidin factor and opsonin. Any other reason? Edema is a good culture media also. So that can also this. And other one thing is that when a child is on steroids, again, it's going to be an immunosuppression. So these are the reasons for the chances of peritonitis being more common in nephrotic syndrome. Okay.
okay.
How do you define peritonitis?
Ascitic fluid tap with the leukocyte count more than 100 cells and with predominantly 50% of neutrophils.
Good. Okay, Harita.
So moving on to other system examination, cardiovascular system, S1, S2 was third and it was normal and there was no murmur. Respiratory system, bilateral RNG was present and RNG was equal on both sides and there was no added sounds. And central nervous system, there was no focal neurological deficit. So diagnosis, it's a 3.5-year-old female child presented with periorbital edema followed by abdominal distension and pedal edema with decreased urine output with past history of similar illness who lost to follow-up and treated partially with examination revealing minimal ascites. This is probably a case of nephrotic syndrome with inadequately treated first episode, now in relapse with mild edema with no features suggestive of steroid toxicity or any other complications.
Okay. How would you want to proceed with this child?
Sir, I want to perform the first essential basic investigations, sir. First, urine analysis.
Okay, do you
What are you
think that
looking at?
this child has got, what type of nephrotic syndrome you think this child has got?
Sir?
What type of nephrotic syndrome you think this child has got?
Ma'am, actually this child was not treated completely, ma'am, during the first episode itself. So we can't define it as a infrequent relapse or also because the child had this relapse after 5 months of the diagnosis, ma'am. And we can't tell it as steroid dependent and steroid sensitive also, ma'am, because the child didn't complete the full course of steroids, ma'am. So I have written it as partially treated nephrotic.
Most likely, what do you think this can be?
Maybe first relapse also, ma'am. First episode relapse.
And what type? What is the type of? What do you think this child has got? Commonest. What is the commonest type of?
Histological types.
Minimal change disease.
Minimal change disease.
Harita, you said steroid sensitive nephrotic syndrome is not, you don't know whether it's a steroid sensitive nephrotic syndrome. So you said initially the child was treated for 6 weeks.
Yes,
after that 6 weeks, what happened?
Child was fine, ma'am. Child didn't have any edema or decreased urine output or any features suggestive of nephrotic syndrome after that 6 weeks of course, ma'am. Now after that, the child having an URA, she had this relapse thing, ma'am. So child was fine in between for those 5 months.
So what is steroid
sensitive?
So what is the definition for your nephrotic syndrome and steroid sensitive? Oh, okay, what is the definition for nephrotic syndrome?
Nephrotic syndrome is a child having a heavy proteinuria, edema, and with hypoalbuminemia of serum albumin less than 3 grams per deciliter.
Okay. Now, when do you call it a steroid sensitive?
Ma'am, when the child is on steroid 2 mg per kg per day and child has attained remission and within 4 weeks of steroid, it's called as steroid sensitive nephrotic syndrome.
Okay, so at least 3 consecutive urine albumin has to be nil. Okay, to call to be under remission. And the other thing is, so you can say this child is steroid sensitive. It's not that you can't say this child is steroid insensitive. So steroid sensitive. And the next thing you committed was this could be can be infrequent, or you were saying about those cannot be an infrequent relapser, right? So coming on to that, what is the definition for frequent relapse?
Frequent relapse is 2 or more relapses in the first 6 months of therapy after stopping the therapy, or more than 3 relapses in any 6 months, or more than 4 relapses in 1 year.
Okay, so this child was inadequately treated, agreed, but this child is having the next episode after 5 months only, right?
Yes.
So for the first 6 months, it has to be 2 relapses. So unlikely it's going to be a frequent relapser. Though we can't say, so don't commit yourself saying it can't be an infrequent relapser, because by definition, actually she might fit into an infrequent relapser here, though your treatment has not been completed. Okay.
Okay.
When the patient was admitted for 10 days in the hospital, that time, did the patient had 3 consecutive samples negative?
Yes, sir. The child had remission when she was staying in the hospital itself, sir.
So on the 10th day itself?
Yes, sir.
Okay.
And coming to one more definition, Harita, what is the definition for steroid-resistant nephrotic syndrome?
Steroid resistance is 2 consecutive relapses when the child is on
steroid resistant.
Resistant.
I'm not asking dependent.
No remission. No remission, ma'am, even after 6 weeks of treatment.
6 weeks of steroid.
Okay, so why I asked you this question was, when I asked you what is sensitive, you told me 4 weeks.
This is 6 weeks. Yes.
Okay, so don't commit yourself with the weeks. Okay, because now the definition has changed to 6 weeks. So when they ask you what is remission, you have to just say 3 consecutive urine albumin being nil. Don't commit 4 weeks, because 4 weeks is no longer taken as resistant also by the ISBN. They consider 6 weeks as the steroid resistant nephrotic syndrome. Okay.
Okay.
Be careful when you're committing. You know the answer, but things when you commit, then that leads on to the other questions from there. Okay.
Okay.
You can go on the investigation.
Investigation, yeah.
Sir, so I would like to perform the basic investigation which is essential at onset, sir, like urine analysis, urine spot PCR, urine culture sensitivity, CBC, RFT, and LFT, sir.
I would like to just want to know what is 1+, 2+, 3+, and 4+.
So 1+ is 30 to 100 milligrams, sir. 2+ is around 100 to 300. 3+ is 300 to 1000. 4+ is more than 1000 milligrams, sir, in dipstick method.
And
why do you want to?
Yeah,
why do you want to do the urine culture?
Ma'am, we have to rule out all the infections before starting steroids, ma'am.
See, generally, a urine culture is not performed in every nephrotic syndrome. Right? Only if they're symptomatic and you think they're urinary symptoms, then you proceed with the urine culture. Even a urine routine, when you do in a nephrotic syndrome, sometimes pus cells may be 10, 15, 20 also, sometimes you might see. So don't mistake it for a UTI, because in any inflammation of the glomerulus, be it nephritic or nephrotic, you might have pus cells. Okay. So only if the child is symptomatic, then you need to go and perform a urine culture. Otherwise, a urine culture is not routinely performed in a nephrotic syndrome. It will misguide you. In case if the urine sample is taken improperly, then you will not know whether to start the treatment. You will wait on the treatment. You will give antibiotics, and things actually take a very different turn. So you need to be careful when you do the urine culture. And LFT, right?
Ma'am, albumin. Albumin also.
Do only albumin. You don't have to do the entire LFT, because when do you think LFT is done in a nephrotic syndrome child? Your SGOT-PT, your transaminases.
Hepatitis C.
Any nephrotic child, suppose the child is on certain drugs, which drug do you think will cause an increase in transaminases?
Cyclosporin, tacrolimus, they are calcineurin inhibitors, they are nephrotoxic.
No, I asked transaminases. I'm talking about LFT.
Transaminases.
LFT, okay. So LFT is
Levamisole will have elevated transaminases, ma'am.
levamisole, mycophenolate mofetil.
Mycophenolate.
Prednisolone also causes elevated
prednisolone.
transaminases.
Yes, that also causes. So the recent guideline says if the child is on steroids for a very long time, then once in 6 months, you might have to, 3 to 6 months, I think, you have to do the transaminases. Okay, so that is when transaminases will come. Otherwise, a routine LFT is not done in a nephrotic syndrome child.
I have a child who's got a secondary cause of nephrotic syndrome. What are the secondary causes where you might want an LFT?
Sorry, ma'am?
Secondary cause
where you might want an LFT. Secondary causes of nephrotic syndrome.
Ma'am, for secondary causes,
where you might want a liver function test.
So you should first say what are the secondary causes of nephrotic syndrome. Then you will be able to answer this.
The secondary causes of nephrotic
infections.
Secondary causes infections will include TORCH, toxoplasmosis, rubella, cytomegalovirus, HIV, hepatitis B.
Even malaria, ma'am.
Malaria with a rash, having a little bit of high
you
blood
said
pressure,
in your initial thing.
Maybe an older child.
Arita, you said no that time why you're looking for rashes, oral.
I was asking you the rashes.
SLE, systemic lupus erythematosus.
Or you have a child maybe on treatment. This child has got, you diagnose this child has got tuberculosis or something. If this child is on a UTT, then you might want an LFT.
Yes.
For any child with nephrotic syndrome, so these are the situations where you may want an LFT. Urine analysis specifically, what are you looking for in urine analysis? What are the things that you're going to interpret and look for in a simple urine analysis?
Urine analysis mainly for protein, ma'am.
Right.
When the child is having a 3+ heavy proteinuria, we can suspect for nephrotic syndrome, and also for urine spot PCR protein creatinine ratio, ma'am. More than 2 suggests nephrotic syndrome.
No, madam was specific for urine analysis.
There is some RBCs in the urine.
Ma'am, I'm not able to say.
Okay, so the lab gives a, lab investigation shows that this child, you do a urine analysis and this child has got some RBCs. So when do you think that's significant? When are you worried?
Ma'am, if the child is having RBC CAS, we can think of hematuria. If the child is having hematuria, we can think of AGN, acute glomerulonephritis, and we should.
No, here the child is having nephrotic syndrome. In a nephrotic syndrome, if the child is having RBC in urine, is what madam is asking you.
Child may have renal vein thrombosis. The child is taking any drugs like cyclophosphamide, we have to ask for.
When do you think it is significant? RBCs in urine? Is there
More
something
than
called
5 More than 5 RBCs per high power field in a centrifuge urine sample.
Sudha, your comment? Microscopic hematuria in a child with nephrotic.
Microscopic hematuria usually you see in a non-MCN disease. Okay. So you said the common is your minimal change. So in your non-MCN, you can have microscopic hematuria. Okay. And the causes could be an FSGS. You can think about an FSGS. IgA nephropathy very rarely can present, even membranous or an MPGN. So all these can present. So, or even a secondary cause like your lupus, that also can present. So whenever there is an RBCs in urine, and it's a true microscopic hematuria, then you will have to think about a non-MCN disease, and you have to be careful while following up this child, because there's a high chance that this child might be a steroid-resistant nephrotic syndrome. It gives you a clue at the beginning itself. Okay, but you need to be careful and you'll have to monitor this child.
Okay.
The complications and all comes later. So when you diagnose initially, this is what you look into.
Okay.
What are the conditions you can have transient proteinuria? In a normal person having a transient proteinuria, what conditions can cause transient proteinuria? Benazir and Charan can also answer.
Orthostatic
Any other conditions? Transient proteinuria.
Commonest you see in your clinics?
Commonest.
The food.
UTI, sir.
Fever.
UTI.
Fever can cause exercise. Excessive exercise can also cause transient proteinuria. So to say transient proteinuria, how many plus will be there? It will be 1 plus or 2 plus or 3 plus. You say transient proteinuria. Below what? Less than 2 plus. Okay. Less than 2 plus is transient proteinuria. So it can be in.
This...
Yeah, carry on, madam.
No, sir. So you should know about the nephrotic range proteinuria and subnephrotic range proteinuria. So which is nephrotic range proteinuria?
3 plus or more, ma'am.
Okay, so there, sir, it's given you that answer to 2 plus is less. So you have to think in that way. Okay, so any nephrotic range proteinuria is 3 plus 4 plus. Less than that, you have to think about other causes also. If it's 3 plus 4 plus, unlikely it's going to be a transient, but still, yeah, you have to keep in mind initially. Okay.
And what are the methods you can use to check for urinary protein? What are the methods used?
Boiling test, it was done earlier, ma'am, but nowadays not done. Now with the urinary dipstick calorimetric test, with the help of the color change, we are giving this dipstick method, ma'am. We are reporting.
Heat coagulation method.
Boiling, heat coagulation.
The boiling method still many patients use. Patients who are in government institutions, when they come for follow-up, I've seen them doing boiling test at home and coming. So still boiling test is being performed. By patients at home itself, they perform.
Sulfosalicylic acid, you can add. These are still in vogue. The dipstick is not available for everybody.
Okay. And you should be very careful when using the dipstick also. You should know how to use it. And it's quite expensive, so everybody can't afford that.
Okay.
So you said about the complete blood count. Again, these are simple tests, I think, which we should know about what we are looking for. In the complete blood count, what are the things that we look for in the child with nephrotic syndrome?
Ma'am, if the child is having any infections, it will point towards it, ma'am.
Okay. What do you look for? Infection high counts, is it? Does it always say that it's an infection? Supposing you have a child who got a high protein count.
Not always, ma'am.
What else can cause? A child with a high count, say 20,000 child is otherwise looking very well. Steroid itself can cause. So, although you look for other evidence of infection, when the count is high, but again, that itself can cause. Anything else you look for in CBC? That count? Not only for an infection, we are ordering a complete blood.
Anemia. Anemia, we have to look for, ma'am. Hemoglobin.
Yeah, why?
For SLE, ma'am.
SLE, hemolytic.
Again, many of our children do not eat well, nephrotic syndrome. Okay. So again, you look anemia. Then anything else? Platelets?
Yes, ma'am. Platelets also, ma'am.
Which condition?
In SLE, there will be thrombocytopenia less than 1 lakh. We can.
Platelets again in a sick child also again is very important. You see the platelets are thrombocytopenia and you have a sick child. Again, that indicates that maybe this child has got some sepsis. Okay, so CBC is very important in a child with nephrotic syndrome. It can give us a lot of clues.
Even your high PCV will tell you sometimes the child is having hyper. That also gives you an idea.
Dehydration is very difficult. Yeah, as Sudha said.
Yes, so that also is very important. You have to even every blood test would be important in your complete blood test. You've written serum C3. So you think you would going to do a serum C3 for all children with the nephrotic syndrome?
No, ma'am. Those who are needed only any extra.
So when do you think the serum C3 will be low? The conditions that causes low serum C3.
Ma'am, SLE, ma'am.
PIGN.
Okay, PIGN.
C3GN.
C3 glomerulonephritis.
IgA vasculitis.
IgA vasculitis, usually the C3 is normal.
MPGN.
MPGN.
MPGN, no longer you have that terminology, but yes, C3G and your triple D, so all that comes under the C3G. Okay, fine. Isotiter,
Ma'am,
you
for
committed yourself as
PAGM,
nephrotic syndrome, right? You think this child is PAGM? Any clues
no,
in
ma'am, not.
history? There are no any clues from history that this is a PIGM?
No, ma'am.
No, right? So
No.
if you think it is not fitting into anywhere, then so what do you say, sir? Ma'am, can they say isotiter when they say it is an
I guess
nephrotic?
not required, madam.
Yeah, I think many of these investigations you have to think about urine culture, isotiter, should be specific based upon the scenario, the clinical presentation of the child and history. And there's no blanket recommendation for every child with a nephrotic syndrome that you do all these tests.
So you do an entire lipid profile? I'm reading
Not
whatever
needed.
you have written.
Not needed.
Not
ma'am.
required. Not
Not
required. So generally you do only the cholesterol. Previously it was defined in your definition also, they had cholesterol in your definition, but now the cholesterol also has been taken off from the definition. But yes, above 200, then it indicates nephrotic. So just a cholesterol should do. You should be careful about the patient's pocket also, right? So you need to know.
Why do you have hypercholesterolemia?
Sir, loss of lipoprotein lipase in urine, and there'll be increased hepatic synthesis also, sir, of VLDL and LDL.
So when do you think you will treat hypercholesterolemia?
Ma'am, hypercholesterolemia need not be treated in all children, ma'am.
When do you think you will treat them? In which children the cholesterol might be elevated for a longer period?
Steroid resistant nephrotic syndrome, they may be treated with statins, ma'am. And also
Not all. No, steroid, again, you have the recommendation from ISPN only when you read the SRNS. Okay. So whenever the child above 8 years of age, not less, usually the atorvastatin is recommended in children above 8 years of age. And if their LDL cholesterol is above 160, or if it is above 130 with any underlying cardiac condition, then you think about treating them with atorvastatin. And before that, the first thing that you should always do is, what should you advise these children before starting on medications?
Physical activity and lifestyle.
Yes. So first would be your diet. First would be your diet and your physical activity. What you follows your child one diet, and if they don't respond, then you plan your child to diet. Okay. When you're so that is what you have to advise, and your physical activity. Physical activity, at least there should be vigorous activity for 3 days a week, and at least 1 hour a day they should be active, and less than 2 hours of your TVs and your idle activities. So that also should be restricted. So this is again given in your ISPN SRNS guidelines. Just go through that. So that is when you would think about treating the hypercholesterolemia.
Okay.
Again, ANA ANCA.
For SLA.
ANCA usually is not done for SLA. ANA,
what is ANCA done for?
Vasculitis.
Vaginous granulomatosis and chronic granulomatosis.
Next, ultrasound abdomen. So ultrasound abdomen, is it routinely indicated by your guidelines? So what do you want to look, what are the things that you want to look in the ultrasound abdomen?
Ma'am, size of the kidney, ma'am.
What do you think will be the size of the kidney in a nephrotic syndrome child? when the child is relapsed, when the child is having nephrotic, overall the child is edematous. So the kidney is also edematous. So you expect a bigger, usually there is renomegaly. Okay. Since you've written, usually as routine, ultrasound abdomen is not indicated, but it's usually for the size, and also you see the echogenicity, and based on that, you just follow them up. Okay.
Madam, does it make any difference with this corticomedullary differentiation or anything of that? They usually give that as an ultrasound finding.
Yes, sir. Yes, sir. So whatever in practice that I have seen, children who have a increased CMD, the echogenicity is increased, they usually have a little difficult course when compared to the normal CMD. Though it is not like proven, or it's just by practice what I'm telling you, sir.
Okay.
So that is where we look into that ultrasound abdomen. That gives us an indirect clue of how the child might progress. X-ray is indicated now in your recent guidelines for all children.
Ma'am, if they had been in contact with any case of tuberculosis.
So in this child was in contact with any tuberculosis, you said no contact. So you're talking about investigation in this child only, right?
Yes.
Okay. So then coming on to MAN2. Okay, MAN2 is routinely indicated. But you already said MAN2 was given in this child 6 months back, right?
Yes, ma'am. Previously, the child was given.
So you want to give it again?
No, ma'am.
Okay. So what are the indications for renal biopsy?
Renal biopsy is done in case of persistent microscopic hematuria before the start of calcineurin inhibitors and steroid-resistant nephrotic syndrome, ma'am. And nephrotic syndrome with extrarenal features like rash, arthritis. Like that.
Okay. So, and those on calcineurin inhibitors, we usually do it at around 30 to 36 months. After 2.5 to 3 years, we repeat it to see whether there are any chronic side effects for this calcineurin inhibitors. So if the child is a congenital nephrotic syndrome, do you think renal biopsy is indicated?
No, ma'am. Not necessarily, ma'am.
So what do you think is?
Genetic testing is needed in a case of congenital nephrotic.
So the school of thoughts have changed nowadays. Before they were saying for congenital nephrotic also we need to do biopsy, but now genetics has come up, and so genetics is what we prefer in a congenital nephrotic syndrome child. And if that doesn't give an answer, then we think about a biopsy. Okay. So coming on to genetics. So when do you do genetics in nephrotic syndrome? Genetic analysis in nephrotic syndrome.
In congenital nephrotic syndrome, when the child has presented less than 3 months of age, we should definitely do genetic testing now. And before transplantation,
family SRN.
Family history, okay.
Syndromic association.
Children.
What are the syndromic associations?
Dennis Dash.
What are the features of Dennis Dash?
Ambiguous genitalia, sir.
Ambiguous.
And Bill's tumor.
Bill's tumor.
What is Mickel-Gruber
syndrome?
What is Mickel-Gruber syndrome?
Sir?
Mickel-Gruber syndrome. Nephrotic syndrome is CNS lesions. Carry on, madam.
Genetic analysis is also done in children infantile onset of SRNS and those who are not responding to tacrolimus. This is what ISBN says. Though IPNA guidelines, they do it for all SRNS. For practical reasons, we have not included those because financial reasons. So we have kept it a little more minimum. Okay, so these are the places when we do the genetic analysis. And now sir was asking about Dennis Dash. So WT1 mutation, if you find a child who's having a WT1 mutation, what extra precautions you need to take when you're following up the child? You've already given the answer, but I'm asking you in a different way.
They're more prone for Bill's tumor, ma'am.
So how will you follow up these children? So in these children, ultrasound abdomen is indicated. You need to do the ultrasound abdomen once in 6 months or so, or 1 year, and you need to follow them up. Okay. So in this children, the ultrasound abdomen comes into is more important. pick up the tumor. Okay.
Okay.
Which secondary form of nephrotic syndrome you would like to do repeated renal biopsy? You will repeat the renal biopsy.
SLE.
SLE. Fine.
This is the commonest histopathology in your SSNS. Already given an answer in the beginning only.
Minimal change disease.
Minimal change disease. Okay. And what are the other types you know of?
Focal segmental sclerosis.
In SRNS, FSGS is more common.
Membranous nephropathy.
Mesangiopathy.
Management of the child.
Ma'am, we started this child on prednisolone at 2 mg per kg per day, ma'am. We plan to give till the child attained remission for 3 consecutive urine samples were checked, ma'am. And child attained remission during the stay in the hospital for 3 consecutive days, ma'am. And following that, we started on alternate day steroids with 1.5 gram per kg per day.
1.5 milligram.
1.5 milligram per kg per day. We treated it as a first relapse.
What is the maximum dose for the 2 mg per kg? The child is 40 kilos. How much would you give?
Based on body surface area.
No, I'm talking about 2 mg per kg
kilos.
only. What is the maximum dose is what I'm asking.
60.
You would give 80 milligram? 60. So 60 milligram is the maximum dose. So 1.5 mg per kg when you reduce, what is the maximum dose? 40 milligram. Okay. Now this is the first episode of nephrotic syndrome. How would you treat this child? First episode of nephrotic syndrome. The first episode of nephrotic syndrome. How would you treat this child?
Ma'am, daily dosing of steroid at 2 mg per kg per day for 6 weeks, followed by alternate day dose of 1.5 mg per kg per day for 6 weeks, ma'am.
And then would you stop or would you taper and stop?
Ma'am, we can stop abruptly, ma'am.
Yes, you can stop abruptly. Okay, so 6 weeks of daily and 6 weeks of alternate day steroid, and then you stop. You have to give it in a single dose or a divided dose?
Ma'am, single dose is better because of compliance, ma'am.
Okay, single dose is better because of compliance, but you can give it either single or in split doses also when you're giving it as daily dose, because sometimes they develop gastritis as a complication. So both are acceptable. Okay.
Yes,
now if this child is a frequent relapser, what would be the first drug of choice?
Ma'am, we should check for the steroid threshold, ma'am. If the steroid threshold is more than 0.7 mg per kg, we can start on steroid sparing agents like levimazole.
No, what is the first drug of choice? Only I asked you. So first drug would be what?
Levimazole.
No, low dose steroids.
Low dose steroids.
Low dose steroids. You said that. So I asked you what is the first?
0.7 mg per kg per day we can do, and if the threshold has increased, we can start with steroid sparing agents.
How long will you give?
The steroids can be, low dose steroids can be continued, and along with that we can start the steroid sparing agents, sir. The child has not attained remission.
You know, this child actually you have treated as a first relapse. How I will follow up this child and what I will tell the mother?
We have advised to follow the child with the steroids on alternate days for 4 weeks, ma'am. And then come for follow-up and to check if the child has attained any remission. And child is symptomatically improving, we can stop the steroids, ma'am.
What are the signs of improvement? The child is improving. What are the signs of improvement? And what are you going to tell the mother? How are you going to follow up? What are you going to see? What are you going to examine the child in your examination? What are the things that are going to look for?
Ma'am, we have to look for the height of the child, whether she is growing adequately, whether she is maintaining the growth velocity, ma'am. And when she's coming for follow-up, we have to check for hypertension. The child is having any feature, any Cushingoid features like weight gain, and hyperglycemia should also be checked for, ma'am. And optal examinations for cataract and glaucoma should be checked.
And what do you think are the signs of steroid toxicity? What are the things that you look for?
Ma'am, hyperglycemia in the child with fasting more than 100 and postprandial more than 140, and short stature, height less than 2 standard deviations for the mean age in 6, and cataracts, glaucoma, osteonecrosis,
Myopathy. Psychosis.
What did you say? Sorry, last one.
Psychosis.
Very important to tell the mother, like when she should come back. What are the warning signs? Can the child have some infections during the course of steroid? Okay, and how will she know when to come back? So all these things are very important. If the edema does not settle, how long should she wait?
What is the commonest complication of steroids? Gastritis?
gastric. You have to advise the mother to give the tablet after a good meal, ma'am. Single dose is preferred because good compliance, because in school going children morning dose is better, because the dose can be missed in the school, ma'am. So we have to advise about the compliance of the drug after a good meal, prevent gastritis. And also if there are any features of sudden decrease in urine output or abdominal distension with periorbital edema, we should advise them to come back. And we have to proceed with again a urine analysis to see if the child is having a relapse, and we should treat accordingly. And if the child is who's on steroid having any abdominal distension, we can suspect of peritonitis, ma'am. And the child may have any respiratory tract infections also. So the child when having respiratory tract infection should be given steroid minimally in those cases, ma'am, during stress period. So
when is steroids indicated? When is testosteroids indicated by guidelines?
Ma'am, not for any regular viral infections or otitis media, ma'am. Should be given only for those infections and prior to any surgeries.
So by guidelines, what they say. So when your exams, you have to be careful. Practice might be difficult. Okay. So in guidelines, they say when a child is on low dose steroids for your frequently relapsing nephrotic syndrome or other condition. So that time you change that low dose alternate day steroids to daily steroids.
Daily steroids.
And the conditions what you said were right. Okay. But that is when you change the alternate day steroids to daily steroids for stress dose. And again, coming on to stress dose, what are the other conditions you would think of giving a stress dose? For which child would you consider?
Before surgeries, ma'am. Any surgeries?
So any child who has received 2 mg per kg per day for 2 weeks in the last 1 year. In those conditions, okay, the last 1 year, then you consider them as immunosuppressed. And for those children, you have to give them stress dose steroids in case of any surgery or burns. And usually we give them hydrocortisone. If the stress is severe, then you give them hydrocortisone and followed by oral steroids. You switch them to oral steroids later. Okay. So that is when you give stress dose. So whenever you counsel a patient, now this child was under remission, you said. Okay. So now you're sending them back with an alternate day steroid. So things that you have to put across to them is, first you have to say, the first sign would be when they relapse. So if they relapse, a periorbital puffiness is what is going to be your first sign, rather than your abdominal distension and other things. So if the mother notices periorbital puffiness, then she should immediately notify the doctor and come and meet you. That is one. Number two, any infections, because any infections can trigger a nephrotic syndrome, and this child is immunosuppressed on a good dose of steroids. So at that time, you have to ensure that they meet the doctor and make sure the infection is treated appropriately. So that is the second point you need to. These are the two common things which is going to come across. They are going to come across. Third is, you know about all the complications. Okay, so all the complications will come up only usually during when the child is relapsing. So your peritonitis or your other things is going to come during remission. So you have to tell them. So you know what are the complications. So one by one you think, and you have to tell them, advise them. Any abdominal distension, any pain abdomen, or if the child is having any blood in urine or any other problems, then they have to bring the child back to you.
And again, the mother will have a lot of queries about what diet should I give my child and what I should avoid.
Ma'am, the calorie requirement will be around as ma'am told earlier, the child can take the normal food what has been taken regularly, ma'am, with a moderate amount of increase in protein with like egg white. Those can be given, ma'am.
How much of protein?
We avoided the mother.
How much of protein? Sorry.
The protein around 3 to 4 grams per kg per day, sir.
That's pretty high, no? Slightly. The recommendation is 1.5 to 2 grams per day.
Okay. And I think that, as I said, they'll have more queries about what should I avoid. Can I give this? Can I not give this? What
salty foods to be avoided, ma'am. Like chips, puppets, and pickles, they should be avoided. Should be advised with the mother, ma'am.
How much salt restriction can they have? Oh, same question.
Now is a question of salt restriction, yeah.
Salt restriction only, ma'am.
So when and how much and how are you going to restrict?
2 milliliters per day, ma'am. 2 milliequivalents per kg per day, ma'am.
So you're going to advise like this to the parent?
No, ma'am.
Usually 1 teaspoon of salt will have 100 milliequivalents. Okay. So 1 to 2 milliequivalents per kg per day is when you restrict them when they're having severe edema. So based on the edema status, then you restrict the salt as well as the water content. But you should know that 1 teaspoon is 100 milliequivalents, and then you divide based on the milliequivalents per kg per day, and then you advise them in severe edema. Okay. In mild moderate edema, again, it reduces further. So there's no say correctly, this is how much you need to reduce. Okay. But as you said, you need to avoid extra salty food, especially your junk food. All your junk food will have extra salt.
Since Madam has talked about edema, a patient who is admitted with you, who's got a refractory edema, how do you want to manage?
The refractory edema, first we have to assess the child is in a hypovolemic state or not, sir, before administering Lasix. So furosemide. So if the child is in a hypovolemic state with edema, we should treat with NS bolus 10 to 15 ml per kg per day, over 10 to 15 ml per kg per day per hour over 20 to 30 minutes, or with 5% albumin at 10 to 15 ml per kg over 30 to 60 minutes. Sir, if the child is not hypovolemic, and we can start with IV furosemide 2 to 4 mg per kg. Along with spironolactone, 2 to 4 mg per kg. So if still the child is refractory, we can add on with metalazone or chlorothiazide around 2 to 4 mg per kg. Sorry, 0.1 to 0.4 mg per kg. And still refractory, we can start on continuous infusion of Lasix, and albumin can also be given, sir. 20% albumin at 0.5 to 1 gram per kg.
Yeah. So the answer is 25%, 20% albumin, 0.5 to 1 gram per kg you're supposed to give, and then give the infusion after following that. That's how we are supposed to manage refractory edema. Okay.
Now coming on to your hypovolemia. Now there's no shock, but you want to know whether this child is having underfill or overfill status. So whether you want to give fluids and then treat the child, or you want to give directly the diuretics. So any ways that you can find out?
The hematocrit we can see, ma'am, any increase in the hematocrit, and also fractional excretion of sodium in the urine, ma'am, should be less than 0.5. We can think of hypovolemia, and potassium index more than 0.6. We can think of, ma'am, and also IVC collapsibility with the inferior vena cava, diameter of the inferior vena.
What is the formula for your fractional excretion of sodium?
Urine sodium into serum creatine by serum sodium into urine creatine, ma'am, into 100.
So when do you think diuretic is really required for a child with nephrotic syndrome?
Ma'am, sorry.
When do you think the diuretic is really required for a child with nephrotic syndrome? When will you prescribe diuretics?
Edema only, madam is asking you.
Does every child require a diuretic therapy?
Ma'am, when child having a moderate to severe edema, ma'am.
Right. Or I have a child whom the mother says this child is looking very bloated, also had a few episodes of diarrhea, and the child has not voided urine. Now I have the question, is there a hypovolemia or hypervolemia? Should I give a diuretic or not in that situation?
No, ma'am, diuretic should not be given, ma'am.
How will you decide? You need to give a challenge. The mother says just a few episodes of diarrhea, and then this child has not voided urine. I am not able to assess the hydration status of the child. So if you find that the pulses are very good, the hematocrit is okay, and this child has gained a lot of weight, then you can give a challenge of, it could be the child has not voided urine, the volume status is very good, then you can give a challenge of diuretic. Otherwise, Sudha, what's your comment? Otherwise, if there are signs of hypovolemia, then I think I would avoid a diuretic in the child.
I think you need to unmute, madam.
Sorry. So a child who's having diarrhea, we have to be very careful because mostly their volume status is going to be compromised. And in that case, when we give diuretic, then we are going to induce AKI also in these children. So you have to be very careful when you're giving diuretics. So make sure the child's volume status is good. And if not, it has to be albumin, or it has to be, first you have to try with your fluid boluses. If not, then you have to consider giving albumin, and with that, maybe you can give a small dose of diuretics. You need to be very careful in such scenarios. What about the use of ACI inhibitors in nephrotic syndrome? When would you consider them?
Ma'am, yes, ma'am, we can give in cases of congenital nephrotic syndrome or steroid resistant nephrotic syndrome. Both AC inhibitors and ARBs can be given, ma'am.
Can both be given as a combination? You said both ACI and ARBs can be given. So I'm asking you, both can be given as a combination?
Yes,
usually ACI inhibitors, what is the side effect?
Hypokalemia, hypertriglyceridemia.
What kalemia? Ma'am? What kalemia? Potassium is high or low? I didn't hear that properly. Hypo or
low,
hyper?
Hypo, ma'am.
the side effect itself is hyperkalemia.
Hyperkalemia.
Okay. It reduces the GFR. Okay. So the potassium also it will increase. So that is why you should not give a combination of ACI and ARBs, because the chances of hyperkalemia is very high in any condition. When you're giving ACI and ARBs is not given as a combination. It has to be you have to be very careful when you're giving a combination. And usually for proteinuria in SRNS children, it is indicated, or even in hypertension. The first drug of choice in nephrotic syndrome with hypertension would be your ACI inhibitors or ARB. Okay.
Okay.
And when you're giving ACI inhibitors, madam said any diarrhea, the child had diarrhea, right? She was giving you a scenario. If that particular child is on ACI inhibitor, what would be your advice? Or whenever you're starting ACI inhibitors, what would be the advice given to the mother? So the commonest infection that these children might have will be diarrhea. Many of them will develop diarrhea. So whenever they are having, whenever the child is on ACI inhibitors and the child is having diarrhea, or if the child is having any severe infection, the oral intake is poor, you have to advise the parent to stop the ACI inhibitors. Otherwise, they will lead on to your acute kidney injury. Fine. How does the ACI inhibitor act?
It will inhibit the angiotensin converting enzyme, which helps in converting the angiotensinogen to angiotensin, ma'am.
Mm-hmm. So what happens in hypovolemia? How is the GFR maintained in hypovolemia? What happens to the afferent arterioles and the efferent arterioles in hypovolemia?
In hypovolemia, there will be constriction, ma'am.
Of?
Arterial constriction will be there, ma'am.
See, whenever there's hypovolemia, the body tries to maintain the GFR by dilating the afferent arterioles. So more blood is coming in and it constricts the efferent arterioles. Okay, so that your GFR is maintained. But what happens when you give a ACI inhibitor is it blunts this constriction of the efferent arteriole. That is why you should not give an ACI inhibitor in a child who is hypovolemic. Otherwise, they will go into acute kidney injury. Okay.
And any other, the mother wants to know, she's very curious, should I give some supplements for my child?
Yes, ma'am. Calcium supplements and vitamin D should be given for these children, ma'am.
All children? Usually SRNS is where it is indicated, the vitamin D and the calcium supplements.
Okay.
Okay. And even if the child is on a long-term steroid, then you would think about it. But an infrequent relapser, usually not recommended.
Okay.
If mother asks, can I give extra protein supplements? That is the commonest question that would be asked to you by the patient.
No, ma'am. Should not be.
So usually you should not give. That's a very common question. All the parent will come and ask you. Because child is losing protein, can I give some protein supplements? They are very curious about that. Okay. So you should make sure, you should tell them you should not give any extra proteins. Because again, as I told you, proteinuria and then glomerulosclerosis, and it's going to worsen the disease.
Okay.
Why do you get hypercoagulability state?
So there is a loss of antithrombin 3 and protein C and S in the urine, which causes an hypercoagulable state.
Any other reason?
Sir, in underfill theory, due to intravascular volume depletion, it may also cause hypercoagulability.
And hemoconcentration.
As well as your immobilization, or when there is raised platelets, okay, your increased fibrinogen, and whenever they have central venous catheters. So that time also they are more prone for thrombosis.
Plus diuretics. So hypercoagulability state can cause what are the complications?
So renal vein thrombosis, sir.
How will you identify renal vein thrombosis?
The Doppler.
First go
Clinically,
clinically.
the child will have severe abdominal pains,
So flank pain they will have.
flank pain, lung.
Oliguria and hematuria.
Yes, sir.
And other than renal vein thrombosis, any other thrombosis they can have?
Cerebral vein thrombosis also.
They can have a cortical venous or sagittal venous thrombosis. So how do they present cortical venous thrombosis or sagittal venous thrombosis? You can have vomiting,
vomiting, headache, seizures.
Vomiting, headache, seizures, and altered sensorium. So they can have some neurological deficit also. Madam, you want to ask any other questions?
Yes, sir. So in case of a steroid dependent nephrotic syndrome, what would be the drug of choice? Or a difficult to treat nephrotic syndrome. What is difficult to treat nephrotic syndrome?
Failure to treat after treating with two drugs like levamisole cyclophosphamide, ma'am, or relapses, infrequent relapses or frequent relapses.
Infrequent relapses if there is steroid toxicity.
Steroid toxicity.
Or a frequent relapse. Or as you said, rightly, failure of two steroid sparing agents, then like your levamisole, or it could be a cyclophosphamide or mycophenolate. So that is a difficult to treat nephrotic syndrome. So in a difficult to treat nephrotic syndrome, what would be the drug of choice?
Rituximab, we can think of.
Cyclosporin, tacrolimus.
So first you should think about cyclosporin tacrolimus. Then you need to, if required, then you can consider rituximab. So coming on to cyclosporin and tacrolimus, what are the side effects of cyclosporin and tacrolimus? What is the common side effects between?
Common is nephrotoxicity, ma'am. And cyclosporin will have hypertension, hirsutism, gum hypertrophy.
Tacrolimus?
And tacrolimus will have tremors, seizures.
One more common.
Posterior leukoencephalopathy. No, ma'am.
Hyperglycemia, diabetes. Okay, and hypomagnesemia also it can cause. Now, which is usually preferred, cyclosporin or tacrolimus in children? Usually tacrolimus is preferred. One is for your children getting gingival hypertrophy, hirsutism. It's kind of unacceptable for the children, so they are not going to take the medications, especially in the adolescents. Okay, and it's also you can give both, but tacrolimus takes over. But tacrolimus is not available in your syrup form. So cyclosporin is given in younger children. What is the dose of tacrolimus?
Tacrolimus is 0.1 to
0.1 to 0.2.
0.1 to 0.2 mg per kg per day in 2 divided doses. Dose of cyclosporin?
4 to 5 mg per kg per day, ma'am.
Okay. How do you into 2 divided doses? How do you monitor these children? Any particular way that you're going to monitor these children? What should be done in follow-up?
Potassium and RFT to be done.
Yes, you have to think. You have to rule out all the for the complications, the side effects. You need to do the blood investigations. Apart from that, what is the other thing that we do for a child who's on tacrolimus and cyclosporin? We need to monitor their trough levels. Okay, so we do monitor their trough levels, and trough levels is usually maintained at around 4 to 6 for tacrolimus and 80 to 120, just like the blood pressure reading you can remember for cyclosporin. All this is there in your guidelines. So you should know your ISBN guide. There are a lot of things given in ISBN guidelines. So just read one each. Suppose you get a SRNS case or a SRNS long question, you have to write about all this. And you also have to mention about this steroid dependent. So depending on the case scenario that they're going to give it to you. Okay. And rituximab. Coming to rituximab, what are the complications? Usually at what age is rituximab indicated?
More than 6 years.
More than 6 to 8 years is when we give rituximab. Okay, 8 years. So now rituximab, what are the side effects?
Lung diseases.
First you go acute. First, then you can go for chronic.
Flu-like symptoms, gastrointestinal disturbances.
So flu-like symptoms is usually for levamisole, okay? And gastrointestinal symptoms is more for your mycophenolate mofetil, the commonest. In rituximab, first would be your infusion reactions, your anaphylaxis and other things. So during infusion is one. Number two is reactivation of any underlying infections. So that is why you need to make sure that you do all the viral markers and before starting on your rituximab, okay? So that you have to think about. And then hypogammaglobulinemia. So that is another important side effect of your rituximab. And it also is dose dependent. How many doses, how many times, cycles you have given. So hypogammaglobulinemia, that leading on to infection. So that is also another side effect. And as you said, your interstitial fibrosis and lung disease. So all this also can be a side effect of rituximab. And what is the dose of rituximab?
375 mg per meter square.
375 milligram per meter square. And it's usually given, how many doses is preferred?
2 divided doses.
Not 2 divided doses. 2 doses.
2 doses weekly. 2 doses.
2 doses, which is given a week apart. Okay. Then if the child, you're considering if it's a frequently relapsing nephrotic syndrome and you're considering levamisole, what is the dose?
2 to 2.5 mg per kg per day in 2 divided doses.
And side effects?
For levamisole, it will be neutropenia, ma'am. So we should have a CBC monitoring should be done. And flu-like illness. Flu-like illness also will be present, ma'am.
Elevated transaminases is the other. Okay. As well as your ANCA vasculitis. So that also can be there as a part of levamisole complication. And coming on to if you're having a child whom you think levamisole is not working, and this is a 3-year-old child, what will be the, and this child is a frequently relapsing nephrotic syndrome, what would be the next drug of choice? Your child is having a frequently relapsing nephrotic syndrome, not responded to levamisole. What is the next drug of choice?
Mycophenolate mofetil, ma'am.
Mycophenolate mofetil or cyclophosphamide? Which would you choose and why?
Mycophenolate mofetil.
Why do you want to choose mycophenolate mofetil over cyclophosphamide? Any particular reason?
The cyclophosphamide has some more serious side effects compared to mycophenolate mofetil, ma'am.
What are the side effects of cyclophosphamide?
The child may have hemorrhagic cystitis, alopecia. They're more prone for malignancy also, ma'am. And they may have oligozoospermia, and especially it will cause gonadal toxicity, ma'am.
Okay. So when you choose in a 3-year-old child, usually we give only one cycle of cyclophosphamide. We don't repeat, we don't go for the second cycle. And it works well in children who are above 5 to 6 years. So in younger children, mycophenolate is a better choice. But if the child is around 6 years, okay, so cyclophosphamide is a good drug of choice if they have not reached adolescence or pre-adolescence age, because that's the ideal time where you try cyclophosphamide. Okay, what is the dose of cyclophosphamide?
That's also 2 to 2.5 mg per kg per day for 12 weeks, ma'am.
So why do you consider that 2 to 2.5 mg per kg per day for 12 weeks?
Ma'am, the trough level should be less than 165 mg, ma'am, totally. If it's more means it will cause gonadal toxicity, ma'am, more than
so the cumulative dose. The cumulative dose should be less than 168 mg per kg. As you rightly said, it will lead on to gonadal toxicity, and that is why I told you that pre-adolescence and adolescence we don't choose, and above 6 it has a better action. Okay.
the other thing is, any other endocrine problems that you would look for in children with nephroticism?
Sorry, ma'am.
Worried about any other endocrine problem you'd be worried about in children? Or you look for?
Diabetes, ma'am.
This says my child is not performing so much well at school. Multiple relapses and child is not doing well. Again, thyroid. I think you look for.
Okay.
Any child with thyroid syndrome, you should have a strong, keep monitoring. Okay, look for clinical signs.
Any particular vitamins you want to supplement? Any particular vitamins you want to supplement?
HCD.
Vitamin D.
Yeah, I think she should be.
Okay, vitamin D.
What do you think would be a prognosis for a steroid sensitive and a steroid resistant nephrotic syndrome child? Now the child is steroid sensitive. Mother is asking you, will my child become all right? What would you think? What would you say?
Ma'am, steroid sensitive nephrotic syndrome, they have very good prognosis, ma'am.
What is the percentage of?
In minimal change disease, around 80 to 90% of the children, they have good prognosis, ma'am. They are completely of the disease when they are treated correctly. In minimal change disease, ma'am. Others like focal segmental glomerulosis, they have poor prognosis, and those with other extra renal complications like SLE, all those will have poor prognosis compared to minimal change disease, ma'am.
So usually SSNS has a good outcome, whereas a SRNS, the outcome is not as good as your SSNS. And it will be carried over to the adult. Okay, even in a SSNS, they say if it is SDNS and an FRNS, then they have to be followed up. We do not know what would be their course. If it's an infrequent relapser, yes. A frequent relapser also usually settles. A steroid dependent, like who are getting calcineurin inhibitors or rituximab, those kind of children, we have to be very careful when you counsel them, even if it is an MCM.
Hello?
Madam, I just have one small question, madam. Thing is, if a patient is having patient is on steroid and gone into alternative dose of steroid and then it has been tapered. Now the patient is completely normal and having a respiratory infection or a URI. Is there any requirement of steroids or anything, madam?
So here are two schools of thoughts. By one school of thought, if the child is an infrequent relapser, then they don't advise a stress dose steroids. But they advise stress dose steroids only when they're on low dose steroids for a longer period. But personally, if you ask me, I would prefer to put them on stress dose steroids because I have seen many a times that they they don't relapse and they are under remission. Otherwise, the other way is if you're doubtful and you do not want to start them on a stress dose steroids, then teach them to do a dipstick. So when they do a dipstick at home daily during the period of infection, and even when they get a 1+ at that time, then those children, when they are put on a stress dose steroids, they do fare well. But this is my personal opinion, sir. It's not
Namalva sir also used to say the same thing. That's why I just asked you.
So it's not given in textbook, but this is the practice, and this is what we have found, and I follow, sir.
Yeah, it's a great, good presentation, Dr. Harita, and Dr. Benjamin has prepared their PGs very well. I think they presented a very nicely, excellent presentation. And overall, the case discussion also very good. And I will invite Dr. P. Ramachandran sir to comment, please, our judge.
Thank you. Thanks for the wonderful opportunity. to be here to listen to this case presentation. First of all, my appreciation to Dr. Harita and colleagues. And, the presentation was very good, very clear. And I'm happy that all of them took part in the answering and the discussion. Is there an echo from my side?
Yes, sir.
Okay.
Mildly it is echoing, sir. Right.
Okay.
Arita, please mute yourself, Arita.
So there was I'm very happy that Harita was able to answer most of the questions. And nephrotic syndrome, the diagnosis is not going to be difficult. There isn't much actually in clinical presentation. But nowadays, the general pediatricians are expected to know a lot. We are not going to have many cases of acute gastroenteritis or many of the respiratory problems. But these are the problems which you will be managing day to day along with the advice inputs from the nephrologist. So good amount of information is expected of you. And the more time will be spent on discussion rather than the clinical examination in nephrotic syndrome. So you have to be quite strong. And I'm happy that she rose to the occasion. And actually, I thought whether Dr. Sudha has already told her all the questions before. She was she's able to answer most of the questions and anticipate. And that was a learning for me. Because frankly, I have not read the guidelines, so probably that is where I lacked. So I should go and read. So thanks for the wonderful learning experience. And thank Dr. Benjamin for preparing. And needless to say, Dr. Sudha was asking a lot of probing questions. And Dr. Radhika was asking a lot of practical questions from the general pediatrician point of view. So overall, I thoroughly enjoyed and I learned. I'm happy that I didn't miss it.
Thank you very much, sir.
Thank you, sir. Dr. Annamalai Vijayaragan, sir. Sir, Dr. Annamalai, sir. Yeah.
So thank organizers for the opportunity. The presenter, Dr. Harita, she presented very well, and I must congratulate her. And she has answered most of the questions put by our nephrologist, Dr. Sudha and Dr. Benjamin. I must thank both of them for the way they had asked the questions and the way the student also answered almost all the questions. I must also congratulate our chairperson, Dr. Radhika, who has put in her views during the discussion. Overall, the case discussion went on very well, and I must congratulate the other PGs also. They also participated in the discussion. Thank you for the opportunity.
So thank you, sir. Dr. Radhika, madam, concluding remark, madam, please.
I think overall, as everybody said, it was a big learning experience for everyone, not only the student. And I think TNSC state actually is doing a remarkable job. You know, like not only the youngsters, I think we also brush up our knowledge. And it's very nice to be with, like the specialist experts in this group, because, although I am in the emergency, I feel I need to know a lot about the basic principles in nephrotic syndrome and also the advances, because we do keep seeing, as Dr. PRC said, we are moving away and we are going to see more of other children with resistance and things like that coming in with a lot of other complications, drug related and otherwise. So I think that's how the knowledge, this current batch of students, they're expected to know, I think, much more than what we all knew. And forums like this can really help us to know more about it and remember and know all the advances also.
Thank you, madam. Thank you. It's almost 3 years we are conducting the postgraduate clinic, and it's really went on very well. And a lot of postgraduates as well as our faculties were benefited because of our program, with their feedback. And I'm really happy that all support of all of our judges as well as students, they are doing very well. And it's available in IAP TNC YouTube channel also. And website, you can go on anytime, you can see your program also. and it will be really very useful. And Dr. Benjamin, sir, you can tell your comments, please.
So first of all, I would like to thank the IAP for giving our college an opportunity, sir. And I would like to appreciate the whole IAP team, and especially Rajendran sir has been so, what do you say, he was always in the behind and then messaging continuously and then keeping us active. And he has really spent a lot of time in dedicating for this particular program. Thank you, sir. It will definitely benefit the students and as well as the faculties, as Madam was mentioning. Thank you once again, the IAP, for this wonderful initiative. And I hope that it continues.
Thank you, sir. And,
thanks to all the organizers.
Yeah, on behalf of IAP TNC, I thank our today's chairperson, Dr. Radhika Madam, and moderators, Dr. Benjamin, and as well as Dr. Sudha. And I thank all the postgraduates for has presented very well. I thank our Vice President, Dr. Annamalai Vijayaragan sir, and I thank our Dr. P. Ramachandran sir, who is always supportive and always is like student, no, he's always closely monitor our classes and he'll ask questions and post questions also. Really, and really, I am wondered Dr. Ramachandran sir has done really very well. Past 3 years, sir is with us, and really happy that we are doing excellent work. And once again, I thank all the delegates as well as faculties for this wonderful program. Thank you very much.
Thank you, sir. Thank you. And Harita, you are very good.
Thank you.
Thank you, ma'am.
Thank you, sir.
Thank you.
Thank you.